We are the Group 5, and today we're going to have our white class presentation about congestive heart failure. Let's begin.
Hi, good day everyone. My name is Rika. Today I am going to talk about congestive heart failure. So what is congestive heart failure? Congestive heart failure is the failure of the heart to pump adequate amount of blood to meet the systemic requirements of the body. It is often referred to simply as heart failure. The etiology can be from failure from either systolic or diastolic heart failure. Systolic heart failure happens when there is an inadequate pumping of blood from the ventricle and reduces cardiac output. Any alterations in the myocardial contractility can produce systolic dysfunction. The most prevalent causes are ischemic heart disease and hypertension. Diastolic heart failure happens when the muscles of the ventricles become stiff and does not fill adequately during diastole. Inadequate filling decreases the amount of blood in the ventricle for cardiac output. The most common form of heart failure is the systolic dysfunction.
Congestive heart failure has two main types. One is the left-sided heart failure, which is the most common type of congestive heart failure. It occurs when the left ventricle does not pump blood properly out of the body. And as the condition progresses, the fluid or blood can build up into your lungs. This condition makes breathing difficult along with the other symptoms of left-sided heart failure. Left-sided heart failure could also be due to either systolic or diastolic heart failure. Another type of congestive heart failure is the right-sided heart failure. It occurs when the right ventricle has difficulty pumping blood to the lungs. When this happens, the blood will flow back into the blood vessels, which causes fluid retention in the extremities.
And now for the risk factors of congestive heart failure. The precipitating cause of two-thirds of heart failure patients is the coronary artery disease or CAD. Some other risk factors are hypertension, advanced age, diabetes, cigarette smoking, obesity, elevated total cholesterol to high density lipoprotein cholesterol ratio, abnormally high or low hematocrit, and proteinuria.
Hi, I'm Queen, and now let us discuss about a brief overview of the basic anatomy and physiology of the cardiovascular system. The cardiovascular system is composed of three main parts: the heart, blood, which is composed of red blood cells, white blood cells, platelets, and plasma, and blood vessels, which is composed of veins, arteries, and capillaries. The heart is a hollow muscular organ that lies in the mediastinum and rests on the diaphragm. The heart's job is to propel and pump blood around the body. The heart wall is consist of three layers, namely epicardium or the outer layer, myocardium or the middle layer, and the endocardium, which is the inner layer. The heart is also composed of four chambers, namely right and left atrium and the right and left ventricles.
The basic work of the heart is to pump blood. The left ventricle does the primary work of pumping, but the left atria, by their squeezing action, contribute about 15 to 20% of the total output of the pump. Cardiac output is the volume of blood ejected by the ventricles in 1 minute. The normal heart at rest, beating about 72 times a minute, ejects about 17 ml of blood at each beat. How large the cardiac output is depends on how fast the heart beats or heart rate and how much blood is ejected with each stroke of the heart or the stroke volume. These can be expressed by an equation: cardiac output is equal to heart rate multiplied by stroke volume. Heart rate is the number of heartbeats per minute. The autonomic nervous system, or ANS, regulates the heart rate through the sympathetic and parasympathetic nervous systems. Stroke volume is the amount of blood ejected by the left ventricle with each heartbeat. At the completion of each filling phase or diastole, the ventricle contains approximately 120 ml of blood or end diastolic volume or EDV. Some of the factors involved in diastolic filling are duration of the diastole. So as the diastolic filling period lengthens, the left ventricle fills with a greater volume of blood. Conversely, as the heart rate increases and the period of diastolic filling shortens, Less blood fills the ventricles and the stroke volume decreases, feeling pressure. Blood flows from areas of higher pressure to areas of lower pressure. The greater the pressure during diastole, the more rapid is ventricular filling. And then last, the distensibility of the ventricle. Increased diastolic distension contributes to stroke volume by increased diastolic filling and also by increased systolic ejection and more complete ventricular emptying. The volume of the residual blood in the ventricle at the end of systole is known as the end systolic volume, or ESV. The volume of systolic ejection and the rate at which it is ejected are related to the strength of myocardial contraction and opposed by the outflow resistance to the ejection of blood from the left ventricle offered by aortic or arterial blood pressure. The more vigorous the contraction, the more complete is the ventricular emptying per beat and the greater is any individual stroke volume. The contractile force of the heart may be modified by the following: sympathetic nerve discharge, drugs, and then last, we have the coronary blood flow. Stroke volume has three factors: the preload, contractility, and afterload. The preload is the end diastolic filling volume of the ventricle. The contractility is a change in the inotropic state of muscle without a change in myocardial fiber length, or preload. And lastly, the afterload, which is the resistance to left ventricular ejection.
Now let's move on to the clinical manifestations of congestive heart failure. Now, if a patient has congestive heart failure, he or she can experience or manifest a lot of different symptoms, since congestive heart failure does not only affect the cardiovascular system, but as well as the other systems and other organs of the body. So, the patient with congestive heart failure can experience shortness of breath. So, the patient can experience dyspnea. Dyspnea is caused by the pulmonary edema or the pulmonary congestion due to the pooling of blood in the lungs. The patient can also experience orthopnea, or difficulty in breathing, or dyspnea on supine position. Swelling of the feet and legs is also visible for patients with congestive heart failure, specifically right-sided heart failure, because the blood from the heart will backflow into the vena cava and into the venous circulation, and it will accumulate in the extremities, causing edema and also jugular vein distension. Pink frothy sputum can also be present because of the increased pressure or increased blood pooling in the pulmonary blood vessels, causing damage to the blood vessels and thus pink frothy sputum. Crackles and rales can also be heard upon auscultation due to the fluid retention or fluid accumulation in the air sacs of the lungs. Swollen or tender abdomen with loss of appetite is also common to patients with congestive heart failure because the blood from the right atrium of the heart will backflow into the vena cava and into the venous circulation, and it will accumulate into the other parts of the body and other organs such as the extremities, the liver, the spleen, the peritoneum, which causes enlargement of the abdomen due to fluid accumulation or ascites. Confusion or impaired memory can also be seen in patients with congestive heart failure because the heart cannot supply enough blood into the rest of the body, including the brain. So there will be psychological issues like anxiety and memory loss or confusions. There will also be fatigue and chronic lack of energy because the heart cannot supply enough blood to the body. Therefore, there will be not enough oxygen supply to the body. This will cause fatigue or decreased inactivity tolerance. Sudden weight gain is also seen in congestive heart failure patients because of the fluid retention and fluid accumulation in the body. Again, these are the few common symptoms of congestive heart failure. Now let's move on to the pathophysiology. The pathophysiology is based on the case of a 65 years old male patient with hypertension, hyperlipidemia, coronary artery disease, and had history of bypass surgery 7 years ago. Patient is a smoker and consumes 5 sticks of cigarette per day. Current medications are atorvastatin, 80 mg per day, and aspirin, 81 mg per day. Patient complains of shortness of breath, which occurs when he performs simple tasks such as sweeping the floor. Reports that he sleeps in a rocking chair at night due to orthopnea. Patient also complains of abdominal pain with a pain rating scale of 7 out of 10, 10 being the highest and 1 being the lowest. Physical examination reveals elevated jugular venous pressure and non-fleeting edema in the lower extremities. Mild abdominal distension is also noted. Liver edges are palpable and is slightly enlarged, 11 cm in the mid-clavicular line. Spleen is not palpable. Pulse is weak and irregular. Crackles are heard over lung fields upon auscultation. An echocardiogram demonstrates systolic dysfunction, mitral stenosis, and tricuspid regurgitation, and an ejection fraction of 38%. Chest X-ray also shows heart enlargement. Blood pressure is 160 over 95 millimeters per mercury. Pulse rate is 80 beats per minute. Respiratory rate is 23 cycles per minute, and temperature is 36.5 degrees Celsius. Patient is diagnosed with both left and right-sided heart failure, and heart valve repair surgery was done for both mitral and tricuspid valve. 10 mg per ml of furosemide and 1 mg per ml of propranolol is given intravenously. Clopidogrel 75 mg 1 tab per day per arm for 14 days is ordered. Enalapril 5 mg per arm is given initially, and 20 mg per day of enalapril per arm per day with propranolol 40 mg per 5 ml are prescribed for maintenance. A low sodium diet is prescribed. Now let's start with the pathophysiology. The precipitating factors of the patient are hypertension, smoking, hyperlipidemia, and history of coronary artery disease. The patient is also 65 years old, which is the predisposing factor for congestive heart failure. So the hypertension, smoking, hyperlipidemia, and history of CAD could cause an increase in vascular resistance. Older adult patients also has a decrease in heart rate because it is part of the physiologic changes in aging, and this will cause thickening of the heart walls as a compensatory mechanism. Now, the increase in vascular resistance can cause increase in afterload of the heart. Increase in afterload can decrease the stroke volume, and decreased stroke volume will also decrease the cardiac output. Going back, the thickening of the heart walls can also cause a decrease in the volume of blood during ventricular filling. And the decreased volume of blood during ventricular filling can also cause decrease in stroke volume and therefore decrease in cardiac output. Now, the decrease in cardiac output could result to many things. First, since there is a decrease in cardiac output, the heart will try to compensate for that. The heart will attempt to increase the stroke volume to increase the cardiac output. So to compensate, there will be an increase in size or thickness of the ventricular wall. The increase in size and thickness of the ventricular wall is called hypertrophic cardiomyopathy. Now, if there is an increased thickness in the heart walls or the ventricular wall, meaning there will also be a decrease in the volume of blood during ventricular filling, and this will result to decrease in stroke volume and again decrease in cardiac output. Another effect of decreased cardiac output is an increase in heart rate as a compensatory mechanism of the heart. Increase in heart rate will also mean a less ventricular filling time, and less ventricular filling time will still result to decrease in stroke volume and again decreased cardiac output, and the cycle will go on. Next, decreased cardiac output will also result to a low volume of circulating blood. This will cause a decrease in blood supply to the organs like the kidney. Now, if there is a decreased blood supply in the kidney, the juxtaglomerular cells of the kidneys will sense it, and it will release renin. Renin will be released by the kidney and will stimulate the liver to produce angiotensinogen hormone. Once released from the liver, angiotensinogen will automatically be converted to angiotensin 1. Angiotensin 1 will go into the lungs where an enzyme called ACE or angiotensin converting enzyme will convert it into angiotensin 2. Now, the direct effect of angiotensin 2 is vasoconstriction. Also, angiotensin 2 will stimulate the release of aldosterone from our adrenal glands, which increases sodium and water retention. An increase in sodium and water retention will cause fluid overload.
Going back, angiotensin 2 causes vasoconstriction, and this vasoconstriction can cause an increase in vascular resistance, therefore increasing afterload of the heart and decreasing the stroke volume and decreasing the cardiac output. The decrease in cardiac output can also result to decreased ejection fraction. In the case of the patient has a 30% ejection fraction based on the echocardiogram. Decreased ejection fraction can result to an increased end systolic volume or ESV. This will also result to the pooling of blood in the left ventricle. The blood from the left ventricle will flow back into the lungs, and this will result to pulmonary edema or pulmonary congestion. Symptoms like dyspnea, orthopnea, and crackles are manifested by the patient. The pulmonary congestion, wherein there is pooling of blood in the lungs, will cause damage to the small capillaries in the alveolar sacs. This will cause a cough with pink, frothy sputum. Going back, since the blood is already pooling in the left ventricle and it already flowed back into the lungs, as the disease progresses, the blood will start to backflow from the lungs into the right ventricle. Blood pooling from the right ventricle will soon reach the right atrium. Blood from the right atrium goes back to the vena cava. Blood will backflow to the periphery and into the other organs, and symptoms like swelling of the extremities, non-pitting edema on both legs, abdominal distension, epigastric pain, and jugular vein distension can be observed. Also, because of the decrease in cardiac output, it will also cause a decrease in blood supply for the rest of the body. And symptoms like fatigue, decreased in activity tolerance, weak pulse, and weight gain can also be observed. In the case of the patient has 2 kg to 2.5 kg weight gain per week. That is the pathophysiology of congestive heart failure.
Now let's move on to the treatment for congestive heart failure. Now we have the pharmacological management for congestive heart failure. For the congestive heart failure drugs, there are several medications that can be used to treat congestive heart failure. First are the angiotensin converting enzyme inhibitors or ACE inhibitors. These drugs open up narrowed blood vessels to improve blood flow. This can decrease peripheral vascular resistance, therefore decreasing afterload, then increase stroke volume, and increase cardiac output.
Next are beta blockers. Beta blockers are drugs that reduces blood pressure and slow a rapid heart rhythm. Next is diuretics. These drugs can reduce your body's fluid content and relieve fluid overload. Congestive heart failure can cause your body to retain more fluid than it should, which is caused by the renin-angiotensin aldosterone system, as what we have discussed in the pathophysiology. Surgical management can also be done for the treatment of congestive heart failure. If medications aren't effective on their own, more invasive procedures may be required. Angioplasty, a procedure which opens up blocked arteries, is one option. Your cardiologist may also consider heart valve repair surgery to help your valves open up and close properly. Now let's go to the clinic and discuss the diagnostic tests. Now let's move on to the diagnosis of congestive heart failure. So there are varieties of tests that can be used to diagnose heart failure. First is electrocardiogram. Electrocardiogram, or EKG or ECG, records the heart's rhythm. Abnormalities in your heart rhythm, such as rapid or irregular heartbeat, could suggest that the heart walls of the heart chambers are thicker than normal, which is one sign for heart failure. Next is echocardiogram. An echocardiogram uses sound waves to record the heart's structure and motion. The test can determine if you already have poor blood flow, muscle damage, or heart muscles that does not contract normally. MRI, or magnetic resonance imaging, is a diagnostic tool that takes pictures of the heart with both still and moving pictures, and this will allow the doctors to see if there is damage to the heart. Stress test is a diagnostic tool that shows how well your heart performs under different level of stress. Making the heart work harder makes it easier for the doctor to diagnose problems. Next is the blood test. Blood tests can check for abnormal blood cells and infection. They can also check the level of the BNP, which is a hormone that rises with heart failure. Lastly, cardiac catheterization. So this diagnostic test will show blockages of the coronary arteries. Your doctor will also insert a small tube into your blood vessels and thread it from your upper thigh, arm, or wrist. Now, let's go to the nursing interventions. So the first nursing intervention is monitor for signs of respiratory distress. So we should provide pulmonary hygiene as needed, administer oxygen as prescribed, keep the head of the bed elevated to avoid orthopnea, and monitor ABG levels. Second, monitor for signs of altered cardiac output, including pulmonary edema, arrhythmias, including extreme tachycardia and bradycardia, and heart sound changes like crackles and wails. Number 3, evaluate the fluid status. Maintain strict fluid intake and output measurement. Monitor daily weights. Assess for edema and severe diaphoresis or sweating. Monitor electrolyte values and hematocrit levels. Maintain strict fluid restriction as prescribed. Fourth, administer prescribed medications, which may include antiarrhythmias to increase cardiac performance, diuretics to reduce venous and systemic congestion, iron and folic acid supplements to improve nutritional status. Fifth, prevent infection. Sixth, reduce cardiac demands by keeping the body warm and scheduling nursing interventions to allow for rest. Seventh, promote adequate nutrition, maintain a high-calorie, low-sodium diet as prescribed. And lastly, as appropriate, refer the family to a community health nurse for follow-up care after discharge. That is the end of our wordless presentation about congestive heart failure. Thank you for watching. Stay safe and God bless us all.